Perfect. Thanks so much for that introduction, Tracy. As you said, we're hoping to give an engaging presentation today about what nurse educators should know about accommodations for nurses with disabilities based on the findings of an international scoping review of the literature. Next slide, please. So before we begin, we'd like to just start by acknowledging that Brandon University has campuses on both Treaty 1 and Treaty 2 lands, and we are a gathering place for people from many backgrounds around the world. In this way, we carry on the Indigenous customs of our home in Brandon. We acknowledge Brandon is on shared territory between the Dakota Ayate, the Anishinaabe, the national homeland of the Red River Métis. Today, many other Indigenous people call Brandon their home, including the Aninu, Anisi-Ninnuik, Denisuline, and Inuit. I'm also currently located in Toronto, so I'd like to recognize that I work and live on traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples, which is now home to many diverse First Nations, Inuit, and Métis people. I also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So the plants, animals, and people who share their history and the traditions on the land and water of this area deeply influence our gatherings like this one today. So thank you all for sharing this space with us. Next slide, please. So we'll start off with a brief overview of sort of what we're planning to cover today. First, we'll begin with a short introduction to kind of set the context and highlight why this topic is increasingly important in nursing. Particularly, we'll look at why accommodations are needed in relation to workforce sustainability, safety, and equity. We'll then briefly touch on accommodation legislation, including what responsibilities exist within the Canadian context, followed by a short kind of myth-busting section where we'll aim to challenge some common assumptions about accommodations in nursing. After all that, we'll walk through some of our research methods and main findings and highlight what these findings mean for educators in clinical learning environments. And finally, we'll leave time at the end for questions and discussion. Next slide, please.
So a global nursing shortage has been declared, which has led to increased focus on recruitment and retention efforts. One effort has focused on enhancing recruitment and retention initiatives for healthcare professionals who experience disabilities. However, a scoping review by Barker found that nurses with disabilities may leave the profession of nursing due to ongoing persistent symptoms. However, a large factor was related to negative work environments and a lack of workplace accommodations. Therefore, there's a call for accessible nursing practices that create diverse and equitable, resilient healthcare workforce. So there's some implications there in terms of providing supports to nursing students who experience disabilities. However, research finds that nursing students who experience disabilities often describe inaccessible learning environments and experience challenges obtaining necessary accommodations. So similar findings to those who are practicing nurses who experience disabilities. In addition, in nursing education, many nursing faculty report limited guidance and resources on how to support students who experience disabilities. Therefore, we felt that additional research was required to better understand both accessibility and accommodations in nursing practice. And we sought to use this information to also inform educational practices. And so although it is only Savannah and I discussing our research here today, there is a much larger team involved in this study. Marian, who's in the audience, was our librarian support, but we also had Ryan or Schira providing supports, Laura Van Mulligen, Joanne Winsor, and Jennifer Adair. So since we were talking about accommodations, we should also discuss accommodation legislation. So workplace accommodations include modifications, adjustments, and/or changes to the work environment, as well as practices that enable individuals who experience disabilities to perform their role safely and effectively. Access to workplace accommodations is recognized as a human right, like the right to vote, the right to due process, the right to live discrimination-free, and is a critical component to equitable employment and education. So that means that employers and educators have the legal obligation to provide reasonable accommodations in Canada, as well as many other areas throughout the world. The accommodation process usually begins with an employee identifying a need or a student identifying a need. Employers and academic institutions have the legal duty to accommodate up into the point of undue hardship. So accommodations are a shared responsibility between the employee, the employer, and sometimes unions. Often in nursing, unions are involved in nursing practice. The employer may request supporting documentation, but often are not provided with a full diagnosis. The focus rather is on removing barriers to support that safe and effective work. Accommodations provided aren't always the employee's specific request. So an employee might make a request for something that they might find supportive, and then it would sort of be determined if that request was reasonable or unreasonable, or perhaps could be accommodated in a different way. So accommodations are typically considered unreasonable and would not be reasonably accommodated for a few reasons. The first would be if an accommodation request was determined to pose a threat to the health or safety of others, then that would be considered unreasonable. If the request results in a substantial change to an essential element of the job description or nursing education, the curriculum, then it would be considered unreasonable. If it requires a substantial alteration in service provision or the educational opportunity, and if it imposes an undue financial hardship to the employer. So the undue hardship is determined by each employment setting or each academic setting. So the foundation for determining undue hardship looks at, the number of employees, the size of the organization, the supports and resources available within that organization. So that threshold of undue hardship differs based on that particular setting. So small organizations have a lower threshold, much larger organizations have a higher threshold to meet that undue hardship definition. So accommodations are case by case. It's not a one size fits all solution. There's something else that is also considered, and it is something called saturation. So saturation means that the setting has reached this point of maximum capacity, so that we can't necessarily add additional accommodations because that setting no longer has the capacity to accommodate. So for example, in nursing, an accommodation might be that nurses aren't able to work night shifts. So if you have a large setting with lots of different nurses employed, they might be able to accommodate having a few nurses with that request. However, a smaller organization might only be able to accommodate one nurse. So it depends on the setting, it depends on the specific need. So if in my setting, I have 5 nurses who have all requested this specific accommodation, I may have reached that point of saturation after 2 or after 1. And so therefore, a couple of nurses would be accommodated, but not all of the nurses in that specific situation it would be undue hardship because that institution has met that point of saturation. So of course, there are difficulties with the accommodation model. Again, it's case by case. It's not one size fits all. There might be constraints on the employee as well as the employer. Um, Often there's a reluctance to access accommodations due to experiences of stigma and discrimination. Also, if the employee leaves the setting, the accommodation is no longer in place or available to support others who might benefit without going through that accommodation model. So given this, there's a move towards accessibility. So in Canada, we have an Accessible Canada Act, which is mandating that our institutions create barrier-free settings by January 1st, 2040. So a barrier within this act is defined as anything physical, structural, technology-based, or attitudinal that hinders someone's full and equal participation. So institutions, both nursing practice and academia, should be taking steps today to address this mandate, which is, coming into effect in less than 14 years.
So with that in mind, this slide sort of addresses some common myths about nurses with disabilities and the workplace accommodation process. So starting with the first one on the left there, the assumption that nurses with disabilities are unable to provide safe care when evidence actually shows the opposite. Nurses with disabilities can and do provide safe, competent, and high quality care, particularly when appropriate accommodations are in place. In fact, it's the lack of support that can create safety risks, contribute to burnout, and push skilled nurses out of the workforce. Moving on to the middle myth there, the second myth that accommodations create an unfair advantage or reflect favoritism. In reality, accommodations are intended not to give someone an advantage, but to level the playing field. They ensure that nurses with disabilities can meet the same competencies and professional standards as their peers. It's not about giving anyone an unfair advantage. Finally, there's a common perception that perhaps employers may not be inclined to accommodate. However, in many contexts, including here in Canada, as Andrea just mentioned, employers have a legal duty to accommodate under human rights legislation up to the point of undue hardship. So these policies are not just in place to support workers, but also to promote safer and more inclusive workplaces overall. Next slide, please. So, a little bit about our research and where we're coming from with our team. We sought to map out the existing body of knowledge on workplace accommodations for nurses with disabilities. And in doing so, we also aim to identify key gaps that are present in the literature. Importantly, we were not only interested in what accommodations exist, but also the organizational processes that influence whether and how nurses actually receive these accommodations. So to achieve this, we conducted a scoping review following the JBI methodology. This approach is well suited for broadly exploring a topic, especially when the literature is diverse, but not yet well synthesized. We performed a comprehensive data search of international literature without restricting by jurisdiction, kind of aiming to get that global perspective. This allowed us to capture a wide range of perspectives and policies across different healthcare settings. We also used a working definition of accommodation from the Canadian Association of Supported Employment. And this definition specifically emphasizes that accommodations are any changes to the work environment or employment conditions that enable individuals facing functional limitations or systemic barriers to effectively perform their job. So this definition helped guide our inclusion criteria and also ensured consistency in how the team interpreted accommodations across all the studies. Next slide, please. So we piloted our strategy with 15 articles sort of before completing the full search. The full search did yield around 6,000 articles with about 1,400 duplicates, and we removed those. And following abstract and full text screening, about 20 articles met eligibility criteria and were then included in the review. Next slide, please. So while our search strategy did not restrict by geography, the available literature in this area appears to be concentrated in higher income countries, with the majority, so around 60%, originating from the United States. Two publications each, so around 10% each, were originated from Canada and Australia, respectively. But as a result, these findings do reflect healthcare systems, workplace structures, and regulatory environments that are specific to high income contexts. So, because of this, we can't generalize our findings beyond similar settings. The experiences of nurses with disabilities, as well as the feasibility and availability of accommodations, may differ significantly in other healthcare contexts. Next slide, please. So, following us conducting this scoping review, we found a range of formal and informal workplace accommodations and assistive devices identified across the studies. So, thinking just about formal accommodations, we'll get to self-accommodation in a second, but for formal accommodations, the most commonly reported was reassignment to alternative positions, followed by scheduling changes such as reducing hours or fewer night shifts. Some studies also described modified duties or adjusted job descriptions, as well as ergonomic supports like sit-stand desks or specialized chairs. Other accommodations included reduced lifting requirements, protected time for medical appointments, and additional or more regular breaks. And less frequently, we also saw mention of the audio recording reports, travel restrictions, or exemptions from overtime. The studies also described several employer-provided assistive devices, for example, audiology-related tools and visual supports. This highlights that accommodations can take many different forms, ranging from changes to the job structure, but also use of supportive technologies. Next slide, please. However, one of the most striking findings from our review was that the most common form of accommodation was self-accommodation. So around 50% of the studies included mentioned self-accommodation. This means that instead of going through official processes, many nurses are quietly adapting their work on their own to sort of manage their needs without seeking formal supports. So self-accommodation can take a number of different forms. For example, someone might modify or avoid tasks that feel physically or cognitively difficult, trade shifts with peers to better manage their fatigue or any other symptoms they're feeling. Others may purchase or use their own assistive devices rather than employer-provided devices. But the implications of self-accommodation goes beyond the individual. It shifts that responsibility from the institution to the individual rather than addressing needs through formal systems of support. So over time, this can contribute to fatigue, delayed disclosure, and an increased risk of burnout and overall, taking a step back and looking at the broader impacts, it can even impact workforce attrition. Next slide, please. So why would someone feel the need to self-accommodate rather than seeking formal accommodations? We found that nearly half the studies identified unclear processes for requesting accommodations as a key barrier, so around 45% of studies. Other commonly reported challenges included experiences of ableism or stigma that Andrea mentioned earlier, reluctance to disclose disabilities, and also a limited availability of accommodation options. A smaller proportion, around 15%, also noted a lack of awareness of accommodation rights or options as well. Importantly, though, managers played a dual role. In some cases, they offered studies highlighted that supportive and collaborative managers are key facilitators to accessing accommodations. However, around 30% found that unsupportive managers created significant barriers as well. So they can play sort of a dual role. Next slide, please. The slide sort of highlights those three most common reported barriers that we just spoke about. So, starting on the left, unclear pathways to accommodations. So, many students, or sorry, many nurses simply don't know where to go or how to initiate the process, especially once they enter clinical environments. In contrast to academic accommodations, which may be more structured, that clarity doesn't always carry over into placement settings or like formal clinical placements. As a result, people are sometimes left asking, who do I even ask or who do I even go to learn more about this? And that uncertainty can delay or even prevent support seeking. In the middle is ableism and stigma. So even when supports exist, sometimes there's concerns about how I might be, for example, perceived by others um, for accessing this accommodation, and that can sway someone's decision to disclose as well. So there can be kind of subtle messages from peers, assumptions about are they resilient enough to be a nurse or are they capable enough to be a nurse and do the job well? That can make people feel the need to prove themselves, go beyond their limitations. Sometimes that translates to an inner dialogue, why, sorry, maybe I should just push through my any challenges I encounter rather than asking for support or asking for help. And finally, on the right, limited options in terms of accommodations. So in some settings, even when accommodations are requested, the actual range of available supports might be hard to implement. They might be kind of narrow or non-personalized. This can make it feel like there aren't really viable options or that requesting support could create, for example, an additional burden to the team, things like that. So together, these barriers lead many to rely on informal self-accommodation, not because they don't need the support, but because accessing it feels, unclear or impractical or even risky somehow. Next slide, please. So the slide highlights what happens when accommodations aren't provided. So across the review, several studies describe situations where nurses' accessibility needs could not be accommodated at all. So looking at the specifics, about 20% of articles mentioned cases where lifting restrictions were not accommodated. Similarly, around 15% described a lack of modified work environments. And at the same time, some restrictions, like these lifting limitations, were accommodated in certain settings, but not in others. This may be reflecting differences in institutional policies, available resources, thinking back to the concept of saturation that we kind of started off with, and overall system capacity. Importantly, the impacts of non-accommodation extend beyond the individual nurse that affects workplace sustainability, team capacity, and overall kind of the ability to provide care and the access to care in communities. So, all to say, this is not just an individual issue, but also a broader systems level concern that garners attention. Next slide, please.
So, as Savannah mentioned, reassignment was the most common accommodation provided. So, reassignment can look like many different things. In our scoping review, reassignment was often described as offering an alternative position to the nurse. So, if the nurse was unable to meet the requirements in a particular setting or a particular job description, then they may be reassigned to another area, such as moving from a hospital-based setting to a community-based setting or something like public health. Ideally, when we had first discussed the scoping review, we had also wanted to look at accommodations provided based on different settings. So what accommodations are provided in hospitals, what accommodations are provided in long-term care or community. However, we weren't able to do so because most of the studies reviewed looked at a variety of settings rather than just one particular setting. And when we were going through in our analysis, it was very difficult to tease out what accommodations were available in each particular type of setting. So we were only able to provide more of a general type of report. However, in terms of offering accommodations, in particular the reassignment piece, education level was often discussed. So it was found that the higher level of education, the more available positions and the easier it was to accommodate. So an RN had more opportunities available to them compared to an LPN, or a nurse practitioner even had even more opportunities available to them as compared to a registered nurse. So higher levels of education often increased opportunities for accommodations. So as employers have the legal obligation to accommodate, the nurse would not need to apply for a new position. The employer would be required to make this new position available to them once available. So it, in some instances, might require the nurse obtain some additional education to meet the requirements of the new position. So for example, if I didn't have experience in dialysis, I might be required to take certification. Although reassignment is provided, it does still remain problematic. So as a nurse, I might be reassigned to a highly desirable type of position, but I might actually have less seniority than other nurses who might have been interested in this new vacant position. And so that can lead to conflict with colleagues. You know, why did this person get this position when I have more seniority? So there's a lack of understanding there, and there might be a lack of understanding with management, because remember, when we're talking about disclosures, management might be aware of the accommodation need, but not aware of a diagnosis. And so that can create some challenges. In addition, scheduling changes were also commonly discussed. So in our review, we found that scheduling changes often meant reducing EFTs. So for example, moving from full-time position to maybe a 0.8, reducing the length of shifts, might be breaking up long stretches of 7. So maybe the maximum amount of shifts I'm able to work in a row is 5 or 4 rather than 7 or 8. No overtime came up as accommodation. No night shifts came up as an accommodation. And also something else that came up was ensuring that breaks were provided, and for some individuals, an additional 15-minute break for each shift. The scheduling change might also go hand in hand with reassignment to another position. So if the accommodation was that the nurse couldn't work more than 8 hours, but their position was 12 hours, they might be reassigned to a different unit or setting where 8-hour shifts are the norm rather than a 12-hour shift. So what does this mean for us in education? So one of the reasons why we wanted to do this particular review was because in education, when we receive accommodation requests for students in health studies, sometimes us as educators have difficulty understanding, is this request reasonable or unreasonable? Or often what you hear said is, well, will employers accommodate this? Once the student's in practice, is this something that an employer would accommodate? And so we wanted to gather that additional information to answer some of those types of questions. So how can nurse educators use this information to assess and determine if an accommodation request is reasonable? So again, some of the things that came up was reassignment to alternative positions, scheduling changes, modified duties, ergonomic workstations, reduced lifting requirements, increased breaks or regular breaks, assistive technology in community-based settings. A travel restriction came up. So travel restriction was no like driving in the car no longer than 1 hour, or in some instances, 3 hours over this day or 8 hour period of time. So identifying some areas that were commonly accommodated can serve as a place to start, to begin improving accessibility to meet that 2040 mandate. So examining the accommodations that are commonly required, as well as those that cannot be provided or were not provided, offers some insight into system barriers that can be universally addressed to improve access. So suggested changes to environments. The environmental change was sometimes there just wasn't enough room at the bedside in order to for this nurse to use this lifting device, or to allow a nurse to use a wheelchair in this particular type of setting. So sometimes the setting was a challenge. So some suggested changes could be improved access to technology that could be made available to all nurses and all students, such as audiology devices on phones, large print, for medication records and documentation, larger computer monitors, ergonomic workstations for all, use of recording devices for documentation as well as for communication at shift change, availability to use microphones, increased space at patient care areas, strategic placement of ramps rather than stairs, readjustment of difficult work schedules, having protective time for breaks and break relief. So these modifications would benefit all nurses, but also would ultimately enhance patient care. So we can ask, what things can we do for all? And so in nursing education, we can use this to kind of as a step moving forward. So can we address difficult schedules for students? So part of that could be our clinical schedules. So when we survey students in the Department of Psychiatric Nursing, more students are reporting that they prefer block clinicals. So, several clinical shifts a week rather than when clinicals are integrated with theory courses. So just once a week while they're taking theory as well as lab. Providing quiet areas for documentation, or protected time for students to engage in documentation, allowing voice-activated documentation tools, ensuring structured breaks are provided for students and that those breaks are, reasonable lengths of time. Using tactile and auditory feedback tools, so beepers or vibration devices that prompt when there's a bubble in the IV line rather than relying on, the auditory, or sometimes vice versa. It's also found to improve accessibility when we provide examples or templates for care plans, documentation, or journaling types of assignments. When we are able to clearly explain learning objectives and communicating how the task that we're asking a student to complete meets those learning objectives and how it connects from one course to another or one year to another. We can also survey students about field work or clinical challenges and barriers and try to address some of those changes or challenges for each cohort. We also, as instructors, need to reflect on our own biases and our own experiences. We need to address stigma and discrimination, as that is commonly reported as often the main barrier that students as well as practicing nurses encounter. And in education, we also have accessibility professionals that we can work with and we can collaborate with to not only help determine if accommodations are reasonable, but as well as taking steps forward to promote accessibility. So why does this matter? So every person everywhere typically does better when they feel accepted and supported. And in our review, that stigma and discrimination, it was found so common. And so that's a attitude barrier that needs to be addressed. In our review, we found that accommodations helped support success and actually helped to improve care. Safety issues were not discussed or identified in any of the 20 articles that we reviewed. And actually, managers who may have initially been reluctant to provide accommodations actually often reported positive experiences once accommodations were in place, which helped reduce some of that initial reluctance to hire other nurses who experience disabilities. As nurse educators, we can begin small with manageable changes and build on those changes each year or with each course. Build on strategies that we're already using and intentionally expand them over time. Over time, these efforts will contribute to more inclusive learning environments. Ultimately, accessible nursing education will better support patient outcomes, safer care, and a more equitable healthcare system. So building accessibility into our education not only supports the learner's success, but also has the potential to improve care that students are expected to carry into their professional roles. So that is what we have for you today. Thank you on behalf of myself and Savannah and other members of our team. And now we'll open it for questions. So I'll stop sharing.